Are you still out there?
Yeah, when is it due?
Well, I think it's posted in your course outline, but either way, it's gonna, right now I have it scheduled to be due on the first Friday in December. It's possible that I'm gonna move that up 1 week just so I have time to mark them before the final exams or the final test at least is going to be done.
Okay, thanks.
Okay, so if I change it right now, I'm thinking the Friday, I think it's December 2nd. If at worst, it'll be moved up to the Friday before that.
Sorry, Professor, where did you post the assignment? Is it posted yet? I was trying to find it.
Yeah, you should be able to see it. Let me just.
Yeah, I'm not able to see it either for the assignments.
Under course information, there's a topic 3 down that says assignment instructions. I'm not sure if we can be much clearer.
Oh, okay, yeah.
Sorry about that. I was looking in the wrong section.
No problem, no problem. Just be careful when you say things, and I'm not pointing fingers at anybody, but be careful when you come out and make something, a statement like it's not there, or you must not have posted it, when in fact, maybe you're just not looking in the right spot. That's all. It's all good. It's all good. Okay, let's talk a little bit about the gastrointestinal system, otherwise described sometimes as the digestive system. What's important to realize about this system is that it is one long continuous tube, and it is organized in 4 distinct layers that have specialties as we move along the digestive system that represent the different functions along this tube. So for example, up in the mouth, there's a tongue, and there's the roof of our mouth, and that leads us to our pharynx, and from the pharynx, we go to an esophagus, and from an esophagus, we go to a stomach, and the stomach is a reservoir, and from the stomach, we're going to go to the small intestine. The small intestine is a tightly coiled tube that leads us to the large intestine that works its way around an ascending branch, a transverse branch, descending sigmoid, rectum, and out. So this is one long continuous tube. Technically, as long as the contents in this tube remain in the tube, it is outside of the body. So in other words, if we don't go through the process first of digestion and then absorption, then the contents of this tube are of no use to us from a biological point of view. So it's one long tube. There's a mucosal layer, a submucosal layer. There's a muscularis, smooth muscle. In most places, it's 2 layers of smooth muscle. One is circular, one is longitudinal. In places where mixing is important, there'll be a 3rd layer. The stomach has an oblique layer, which represents, again, a specialty that's going on in the stomach. And then we have that serosal layer, or the outermost layer, which is mostly connective tissue, that's going to give us help keep the intestines positioned the way that they're supposed to be positioned, and so on. And if we want to get a little bit more complete, wedged right in this area right in here, we have an organ known as the pancreas. And we've talked a little bit about the pancreas by way of examples, because we know the pancreas has cells in it that produce the hormone insulin. But a bigger role in terms of the amount of the organ that's dedicated to this function is digestion. It produces a large volume of enzymes that help with the digestive process. And the goal of digestion is to break down metabolites into small enough components that they can be absorbed. Most of the absorption is going to happen in the small intestine, right? And we have enzymes and we have surface area at the small intestine that favor that particular function. Remember, there were villi and microvilli, and the small intestine is coiled up in a relatively small space, that abdominal cavity. But if you stretched it out, it can be as long as 15 or 20 feet in length, and longer than that when the muscle tone is relaxed. So by the time we get down to the large intestine, most of the absorption has already occurred. A little bit of homeostatic adjustments for some electrolytes and water in the large intestine, but mostly what's going to happen once we're in the large intestine is we're going to push whatever wasn't absorbed out for elimination. Everybody happy with that quick review? About a 10-minute review of the entire digestive system there?
Yes.
Okay. So when we think of the overall functions, we're thinking about an introduction of nutrients to the body through the mouth, and then digestion, absorption, excretion. Those are the big ones as far as functions go. So when we have a tube as the basis for our system, then when we look at pathologies, it's pretty simple to sort of summarize what the pathologies are going to be. We could have narrowing or blockage anywhere along the tube that's going to cause us problems. Depending where that narrowing or blockage happens will determine what functions beyond it we might lose. We could have nervous system or muscular system abnormalities. When we talk about muscular system abnormalities in the digestive system, we're talking about smooth muscle. Whoops, I said 3 there already. I skipped.
I was going to ask about that.
Yeah, you should have. Not sure. Oh, see, that's what it is. I'm just dragging my pen a little bit. I think that's why we ended up with that. And when we get to number 3, we're looking at things like that are a little more specific. Some malabsorption, which might be a problem with available enzymes. We might have, so we could have an enzyme problem there, or we could have scarring. So towards the end of this section, we'll talk about some of the inflammatory bowel diseases, and a lot of what's left over after an inflammatory attack is going to be some scar tissue. That's going to block surface area for absorption to occur. So we can have abnormal secretions, so that's enzymes, or even mucus, for example. So that would include volumes of fluids plus the enzymes would be included in there. And then when we look at signs and symptoms that represent a digestive system problem, we would be thinking about things like vomiting and diarrhea and constipation, and then possibly bleeding. Those sorts of factors will be can point us towards problems with the digestive system. Okay, so what we're going to do is we're going to hit some high spots as we move down this tube. So the first condition that we're going to talk about has got an acronym. That spells the acronym, or spells GERD, which is gastro. And if you weren't sure, anytime you see gastro, you should be thinking stomach specifically. Esophageal reflux disease. But a better word, you sometimes see it as disease, but a better word in this case is disorder. Because GERD is not actually a disease. It's the result of some dysfunction, but it's not actually a disease. It's really a symptom. Most of what we talk about with respect to this gastroesophageal reflux problem is a symptom of something else going wrong in another part of the digestive system that has its effect on the esophagus. So when we look at this, well, the underlying condition is going to be inflammation of the esophageal passageway. So that's sometimes simply referred to as esophagitis. And one of the mechanisms behind why this might happen is if we have an incomplete or an incompetent lower esophageal sphincter. So in this region, the lower esophageal sphincter is the sphincter that is designed not so much to control what empties into the stomach, but more importantly, what prevents the stomach contents from being regurgitated. So it's not a very strong sphincter, but it does exist, and it is designed mostly to prevent this reflux, this regurgitation. You should recall that most of the contents of the stomach is going to be very acidic, and the mucosa in the stomach is designed to withstand that low pH, but the mucosa in the esophagus is not, and this sphincter is designed to protect it. So basically what happens with an incompetent sphincter is it's unable to generate enough pressure to prevent this regurgitation. So you think about conditions where the pressure in the stomach might be chronically high, like possibly in obesity or in pregnancy, for example. There's an increased chance then that this sphincter will fail and there'll be some regurgitation. Does that make sense?
Yes, thank you.
Okay, so another mechanism, which is a little bit more medical in etiology, is what's called a hiatus hernia. So in our passageway through the digestive system, the stomach sits up really against the roof of the diaphragm. And for the esophagus to pass through to the stomach, there has to be an opening in the diaphragm, and that opening in the diaphragm is called the hiatus. And the esophagus is going to pass, and literally what happens is the esophagus passes through the diaphragm, and the stomach develops from that moment forward in our continuous tube. So above the diaphragm, it's esophagus. Below the diaphragm, it's the stomach. And what happens with a hiatus hernia is that the opening is expanded or weakened so that the stomach is able to pass through, especially when it's under some pressure, into the thoracic cavity. Remember, this diaphragm separates the thoracic cavity from the abdominal cavity. So there's two types of hiatus hernia, two main types that we want to be aware of. One is called the sliding type. And in the sliding type, what happens is this opening of the diaphragm gets large enough or weak enough that part of the stomach is able to protrude up into the thoracic cavity. So if we drew a picture of our diaphragm and we had our stomach is actually able to bulge through. In a sliding type. So when pressure's high, the cardiac portion, the upper portion of the stomach is able to slip through. And now you've got a segment of the stomach that's under the same conditions as the esophagus. You might remember that the thoracic cavity is under negative pressure. So when the thoracic cavity is under negative pressure, it creates a little bit of a vacuum in that area. So now we've got an opening of the stomach that can be sort of vacuumed up and has a better chance of being delivered into the esophagus, the contents of the stomach. And the other type is called a rolling type. And in a rolling type, if we draw our diaphragm like that and our stomach, what happens again when the pressure changes, we can have a scenario where the esophagus stays in the right spot, but a segment of the stomach is squeezed through. Again, the opening is weakened, and there's a segment of the stomach that squeezes through, but it's transient. It'll move back and forth depending on the pressure in the stomach. So in that case, in the second option there, what we're looking at is that lower esophageal sphincter stays in the correct location, but part of the stomach is rolled through that hiatus, through that opening, and changes the entire dynamics then of that lower esophageal sphincter. It's going to be sort of stretched open, and contents of the stomach are going to be able to slide in. So when the acidity from the stomach is allowed to travel in, it's going to be exposed to the linings of the esophagus. And that acidity is going to cause injury. And we know what happens when we get an injury. We're going to get an inflammatory response. We're going to get inflammation. So that's going to account for a lot of the symptoms. So we'll come back to that. There's a couple of other types of hernias that we want to look at as well. There are scenarios where the nervous system is inhibited. In the autonomic nervous system, you remember that the parasympathetic division of the autonomic nervous system encourages digestive function. So we could have scenarios where there's a decrease in the esophageal peristalsis. So if we have a decrease in the esophageal peristalsis, we're not delivering the food in a timely way down to the stomach. Normally, it just takes a second or two to go from the mouth to the stomach because the sphincter is typically relatively passive when we're going from the esophagus to the stomach. But if there's poor push, then again, the pressure balance is switched and there's a better chance for some regurgitation to occur. We can have scenarios where there's poor salivary production. That will interfere with transport. Or we can have a problem with the emptying of the stomach. And what that's going to do then is make the contents of the stomach stay longer with more acidity and more chance for this leakage or regurgitation backwards. Okay, so these are just some examples of some causes or reasons for why there would be some reflux. If you throw the dynamics of the passage of food from the esophagus to the stomach, create an imbalance, then we've got an increased chance for some regurgitation. So what are the manifestations? We already know, because we've discussed it, there's going to be some inflammation. So how do you think that inflammation would present?
Pain?
Sure. What kind of pain? Where do you think it's going to be located?
Like heartburn feeling.
Right. So where's that? Where's the location relative to your anatomy?
In like your sternum?
Yeah. So specifically, we describe it as retrosternal, right? It's behind the sternum. So if it's behind the sternum and someone used the term heartburn, what's the thing that we have to rule out? It's probably really important to rule out early.
Heart attack?
Exactly. Exactly. So retrosternal pain is a common symptom. So we have to rule out heart issues because of that location. So, and there's a couple of things that we'll look for to do that. But basically, because it's this retrosternal pain, which is sometimes called not so much by us anymore, heartburn. But your patient might come in and say that's what they have, is they have some heartburn. So we need to rule out heart issues like angina or a myocardial infarction, an MI. And typically we're going to be able to do that because this pain typically is only going to show up under specific circumstances. And one of those is going to be related to your meals. So somewhere around 36 or 30 to 60 minutes after you've eaten. And typically also, again, these are all typical things, and you'll find out if you haven't already, that very few patients present with all the typical signs and symptoms, but if we know all the typical signs and symptoms, we can start to paint a bit of a picture. So it's worse when flexed at the waist, in other words, bending forward, or when lying down. Okay, so this is particularly when it's acute, particularly when the inflammation is new, the exposure to the acids are fresh. So you may even see patients that have some respiratory signs and symptoms, like some wheezing or coughing. And that might be partly due to the reflux causing some aspiration, right? Some of the contents is actually in the esophagus that creates a bit of a gag reflex. So again, you have to rule out some respiratory issues under those circumstances, but based on a history that shows that this is periodical, especially related to a meal, you're more thinking about the digestive system as far as that goes. So a single event is not really a major concern because a single event might happen under any of these types of conditions. A woman who's pregnant may go through it, especially in her late stages of the pregnancy when the baby's pushing structurally with the digestive system, although it can also create weakness in that system.
Sir, I think your screen is frozen.
I don't think it is.
Oh, sorry.
No, don't apologize for that.
Just for a minute.
What?
We lost you for a few seconds when you were talking about, for example, a pregnant woman. We didn't hear the rest.
Okay, all right. So to the fellow that's told me that the screen froze, don't apologize for that because on my end it wasn't frozen, but it's good to let me know that we were disconnected at least temporarily. So you never have to apologize for something like that. That's for sure. I appreciate the politeness, but it's not necessary for that sort of thing. So all I was saying was that when we talk about an acute presentation of esophagitis, it's not a big concern. What does become a bigger concern is if it's chronic. So when we have chronic or recurring, what we're concerned about is what that might lead to. And one of the things that will lead to is what's referred to as esophageal strictures. So with repeated inflammation, we get scar tissue that reduces the opening of the esophagus and reduces its ability to perform peristalsis because we're going to have this scar tissue that represents replaced tissue, not regenerated tissue, so it's different. So we're going to have a reduction in function. So it's going to decrease esophageal And another consideration with chronic esophagitis is a condition called Barrett's esophagus. So it's unfortunately it's still got a guy's name associated with it. And what this refers to is this chronic exposure to the acids and the contents of the stomach is going to cause an adaptation in the cells. You might recall that in the most of the esophagus, the mucosal layer is a stratified squamous epithelium. And some of you, I can see, I can tell, I can feel it. You're rolling your eyes. What are we supposed to remember about an epithelial tissue? But stratified squamous is going to be found where we want to resist friction. You know, right? Most of the outer layer of the skin, the epidermis is stratified squamous, the lining of the mouth and the esophagus is stratified squamous epithelium. But when we get to the stomach, it becomes a simple columnar and sometimes a pseudo, well, let's just stick with a simple columnar epithelium. And with some mucus cells that are going to line the coating of the stomach, and then other cells that we'll talk about in a few more minutes that create the acids in the stomach. In Barrett's esophagus, the contents of the stomach are chronically being exposed to the epithelium in the esophagus. Contents of the stomach are being constantly exposed to the esophagus, and that's going to create adaptation, which in this case means metaplasia. So chronic So remember when we talked about different ways that cells will respond to a stressor. In this case, the stratified squamous epithelium is going to try to convert itself to a simple columnar epithelium to match the environment of the stomach. The problem with metaplasia in this area is it's going to be kind of an incomplete variable type of metaplasia. And when we look at any tissue that shows a variability in cell type, what we're really concerned about then is neoplasia. So this is a risk factor for esophageal cancer.
Sir, what does it say after stomach in the line above?
Causes metaplasia.
Okay, thank you.
Yeah, that's a messy word. That's a messy word the way I wrote it, at least. Okay.
Did you say they change into columnar cells when they go through metaplasia?
Yep, they're going to try to mimic the lining of the stomach, which is a
Okay.
columnar epithelium.
Thank you.
Okay, so it's an incomplete type of metaplasia, and that's what increases the risk for esophageal cancer. So we're careful here, right? We're using the word risk. We're not saying that this causes cancer, but it does increase the risk for cancer at this location. So I think I mentioned before, I don't know if this is an acceptable abbreviation for treatment, but that's what I use for treatment. TX. I think in pharmacology they use RX, but that's strictly a pharmacological treatment plan. This is an overall treatment plan, at least in my books. Okay, does that work okay for everybody?
Yes.
Yeah.
So one of the things we can do is we can try to reduce the contents of the stomach and reduce the pressures that the stomach would otherwise generate by eating smaller and more frequent meals. So sort of minimizing what. So we want to eat frequent but smaller meals. So basically what that means is we're sort of establishing a regular secretion through the stomach. So we're not going to go through all or nothing. Most of us know what it feels like to eat on an empty stomach. We tend to gorge ourselves, and then there's going to be this response. So if you can visualize our homeostatic wave, we like homeostasis to look like this. We don't think this is very good homeostasis. So emptying, being completely empty of food in the stomach and then filling it up is going to result in gastric secretions that will try to meet that acute demand. And then we empty, and then we go acute again and empty, and so it's not a very efficient way. So that's what we mean by eating frequently and smaller meals. So that's something that we can do. We can encourage people not to eat in bed. So in other words, if they sit upright, especially while eating, but certainly afterwards as well. Possibly we might, although this creates problems to the point of our assignment, is antacids may reduce the pH of the secretions. It's probably going to interfere with our digestive capabilities in the stomach as well, but that's a possibility, especially on an acute basis when it's flaring up. And the other thing to consider, I'm just running out of space here, so I'm going to mention it, is that well, actually what I can do is move this up for now. I don't know if you see that bar or not, but I do. Is to avoid foods that we know can inhibit the lower esophageal sphincter. So when we talk about things that might inhibit the lower esophageal sphincter, we're talking about alcohol and caffeine. These are both known to weaken the lower esophageal sphincter, and some of our lipid-based foods. And occasionally, if the damage is enough that there's some restriction in the delivery of food contents from the mouth to the stomach, a surgical procedure may need to be implemented in order to clear up some of the scar tissue, or even in some cases to resect the segment that's been so badly damaged and reestablish an open pathway between the mouth and the stomach. So that's our first pathology in the digestive system. Any questions about that?
No.
All right, let's move down a little further along the digestive tract. We're going to move into the stomach. Got a few things that we'll hit on while we're in the stomach. And this is a category of conditions that are lumped under the heading peptic ulcer diseases. And basically any scenario where there is an abnormal balance between the GI mucosa, which normally protects the lining of the stomach, and the acids that are being produced by the other cells in that stomach. So you may recall that there are some cells that are located in what we call gastric pits in the lining of the stomach. So a gastric pit might look something like this. And this gastric pit is made up of several different cell types. So these are all part of the mucosa and submucosa, but the cells themselves are mucosal cells. So these are going to be the simple columnar cells. And some of those cells there's 4 or 5 distinct cell types that contribute to the production of, so I'm just depicting them in some different colors here, just so that we, in no particular order, but just identify. So what do we have? 1, 2, 3, 4 different cell types there let's make sure we have another one in there. So these gastric pits are found throughout the lining of the stomach and are particularly more concentrated as we move towards the middle and distal part of that stomach. So remember, the stomach from the esophagus, the stomach pouches out, and it's got what's called a greater curvature and a lesser curvature. And within, we have those folds. Anybody remember what those folds were called?
Rubia?
Close. They were called rugae. Does that sound familiar?
Yes.
Yes. For you, it should sound familiar. For some of the others who took anatomy from who knows who, maybe not so much. So what we're talking about is within these large folds, we have these gastric pits with different cell types in them. So for example, we've got a cell type that is conveniently for the stomach called a gastric cell or a G cell. And this cell is stimulated by the vagus. Remember, the vagus nerve was the major parasympathetic nerve. Parasympathetic was going to increase secretions and motility in the GI tract, right? That was the rest and digest division of the autonomic nervous system. So the G cell produces a hormone called gastrin. And gastrin, when it gets released, is going to increase motility and secretions and promote gastric juice production. So this G cell also produces a chemical messenger called histamine. So here we see that histamine is an important chemical messenger for the production of stomach juices. And yet we love to use antihistamines as a treatment for inflammation and that sort of thing. And here we can see that that's going to end up giving us a potential problem in the digestive system. Because we're also, if we block it in one location, we're going to block it in every location if it's an antihistamine. So this histamine is also increased and will help with overall production of the gastric juices and the balances between the different parts of these gastric juices. So that would be one of our cell types that we see in this gastric pit. Then we also see some chief cells. And these chief cells produce something called pepsinogen. Now, does anybody know what pepsinogen is?
The prototype for pepsin?
Very good that you got the prototype in there. So it's when you see that OGEN on the end of a word, it's telling you that it's not yet active. So another cell in this gastric pit is called a parietal cell. And it produces the hydrochloric acid. And hydrochloric acid is what's necessary to activate pepsinogen to become pepsin. And pepsin is a hormone that works on what type of molecule? Sorry, I called it a hormone. I meant an enzyme. It's an enzyme that works on what kind of molecule? Come on, look at the first three letters. What kind of a bond do you think it might break down?
Peptide.
Yes, a bond between two amino acids. If you combine two amino acids, you get a peptide, right? If you combine more than two, you get a polypeptide. Or sorry, the two is a dipeptide and more is a polypeptide. So this is an enzyme that tells you in its name exactly what type of bond it's going to work on to break down. In the digestive process, we know that the juices in the stomach are mostly going to target proteins, and this is one of the pathways for it. Now, the parietal cell also produces something called an intrinsic factor. And the intrinsic factor is a necessary metabolite for us to be able to utilize vitamin B12. If we don't have intrinsic factor, we don't get utilization of vitamin B12. And if we don't get utilization of vitamin B12, we can't make mature red blood cells. And we don't get proper functioning then of the cardiovascular system and to some degree also the nervous system. The B vitamins as a group are essential for the normal functioning of those two systems in particular. So the absence of intrinsic factor is going to create a type of anemia, a B12 deficiency anemia. Then we have a fourth type that's pretty important. The first three are all contributing to the low pH juice that's going to promote the digestion mostly of proteins. But without this fourth cell type, this mucosal cell, we're going to get attack on the mucosa itself. These acids will start to digest the proteins that are found on the membranes of these cells in the stomach lining, unless we coat these cells with mucus. So this fourth cell type is a mucus-producing cell, and it produces mucus by utilizing bicarbonate, and it lines and protects the mucosa of the stomach against that acid. So literally what would happen is if we said that our mucus was produced by this turquoisey cell, the turquoisey cell would produce mucus and line this gastric pit and line the mucosa along the length or the entire lumen of this stomach contents. And the acids would then be found in the lumen of this gastric pit and delivered up into the lumen of the stomach as a whole. But there would be this barrier created by the mucosal cells that protects the underlining mucosa. Does that make sense? We okay with that?
Yes, thank you.
Okay, so that's a quick review, I hope, of what's going on in the stomach under normal conditions. So we can see that there's a balance required between the production of acids and the production of mucus. If we throw that balance out, for any reason, we increase the risk of the acids being exposed to the mucosal layer of cells and causing damage. First inflammation, but eventually destruction. So that's the basis for these ulcer diseases, is an imbalance between the mucus and the acids being produced. So the pathology occurs when there's an imbalance between the mucus production and the acid production. So when we have an imbalance, we could have not enough mucus, or we could have too much acid. So one of the things that we know happens as a result of the stress response is that it tends to inhibit mucosal production in the stomach, and that allows the acids to dominate over mucus. So in fight or flight, the epinephrine signals will inhibit mucosal production, and the acidity is allowed to dominate over the mucus, so we increase the risk for ulceration under chronic stress scenarios like that. So the major location for these types of ulcerations is going to be the stomach for all the reasons that we've just outlined here, but also it's possible to happen in the most proximal parts of the small intestine, the duodenum, because that's the area that's going to be most exposed to the contents of the stomach before exposure to some of the counters to acidity from the pancreatic juices and so on. So the primary locations for ulceration are gastric, okay, I gotta back up here. Duodenal. So basically what that's going to look like is if we have a lining that represents our mucosal lining, and then we have some glands and another layer of tissue as our submucosal lining, then we have our muscularis, and then finally we have our serosal layer, right? We have 1, 2, 3, 4 layers of tissue. So under normal conditions, we have a nice coating of mucus that protects us from the acids in the lumen of the stomach or the duodenum. Now, if we disrupt the balance so that the acids dominate over the mucus or the mucus is reduced with respect to the acids, what that's going to show like is an interruption in the mucosal layer protection, which is going to lead us to exposure of the acids onto the cells of that mucosal layer. And because they are enzymes, the acids and the pepsin is targeting particularly proteins and protein breakdown. It's going to target large components of the cell membranes of these cells and start the process of digestion on these cells, which is going to create erosion. So early on in the erosion process, we may just see a bit of a disruption in the mucosal layer. But if it is allowed to progress, it may dip down into the submucosal layer and then down into the muscularis layer. And if it's allowed to pass through all 4 layers, then we have a perforation. We have an ulcer that's perforated, and that means that the contents of the stomach, in all these cases, contents of the stomach is allowed to escape. And now we have peritonitis. And peritonitis is a life-threatening situation. When acid is allowed to present itself into the peritoneum, it can spread throughout the entire abdominal cavity and become a source of shock and systemic inflammation, and becomes a very life-threatening situation. You know, not all that different than anaphylaxis, although it's not an allergic reaction. Do you follow me on this progression?
Yes.
Yes.
Okay. So the most common reason, the primary etiology, number one etiology is because of a bacteria. This bacteria is called Heliobacter pylori. So initially you go, oh my gosh, that's a mouthful. But we will, first of all, we're going to abbreviate to, sorry, this should be a little p in the proper taxonomy or whatever that word is, p. So we can just abbreviate it to H. pylori. So this is a bacteria, and the pylo part tells you it's going to have something to do with the stomach, because the pyloric sphincter is the sphincter that controls emptying the stomach into the small intestine. So at least this bacteria has a pretty good hint in its name as to the area that it's likely to be found and to the effects that it may have on the mucosa. So this particular bacteria, remember we talked a little bit about how these different organisms have better abilities than others for causing virulence, causing harm to the host. this type of bacteria has a flagella, so it has a motile tail. So the flagella, so we'll say movement by the flagella allows this bacteria to evade the acids. So what it's able to do is to burrow down into the mucosa. To target the epithelial cells below the layer of mucus. So at the same time it's avoiding the pH, it's making contact with the epithelial layer, the mucosal layer of the stomach lining, and it's going to create an inflammatory response. And it's going to ultimately initiate apoptosis and atrophy of those cells that are now being exposed to the acids that were created by this pathway that this bacteria took to get to the mucosa. So we're going to give rise to inflammation. And ultimately, so this bacteria disrupts the balance between the acids and the mucus. So the interesting thing about this bacteria is that across the world, there's about a 50% prevalence. In other words, about 50% of the world's population has this bacteria as part of their normal flora, part of their normal digestive growth. But 50% of the population doesn't get ulcers. So we know that this prevalence of this bacteria is part of the problem, but we don't know why some people will ulcer as a result of this exposure and others are protected from it, don't seem to have the same kind of problem. But what we do know is that in those people that do have an ulcer, about 80% of the cases are because of this bacteria. So I know these numbers can sometimes be a little bit confusing, but what we say with this is about 50% of the world's population colonize Okay, so but a relatively small percentage of the world's population ever get ulcers. Okay, so again, these are not numbers that I'm going to ask you questions on, but it's just to give you another part of the puzzle. And we say that about 80% of those with ulcers are believed to have the Helicobacter pylori bacteria as the cause. So that leaves us with about 20% of those with ulcers. Anybody have any idea where the rest of the people with ulcers get it from?
Or diet.
Nope. There's actually not a dietary link to this problem. We did at one time think so, but not anymore. It's very close to everybody in this discussion's choice of profession.
Is it stress?
Well, stress is definitely a risk factor, but I just wrote it down. The other 20% of those that have ulcers are chronic users of non-steroidal anti-inflammatory drugs. And of course, if you're somebody that colonizes Helicobacter pylori and you take non-steroidal anti-inflammatories, that combination significantly increases your risk for ulceration. So you might remember, I think we talked briefly about it when we were talking about the pain pathway and also a little bit when we're talking about inflammation. But we have an enzyme. There's two variants on this enzyme. One was abbreviated as COX-1 and the other COX-2. Those are cyclooxygenase enzymes that convert some of the lipids, fatty acids from damaged cells into prostaglandins. And prostaglandins signal the gastrointestinal system to promote mucus and also are anti-inflammatory. So when you take the anti-inflammatory, you successfully prevent the formation of prostaglandins, which deals with the inflammation problem, but it also interferes with the production of mucus. And therefore we create that imbalance. Do you follow that pathway?
Yes.
Yeah, we're okay with that?
Yes, thank you.
Okay, great. So again, there are some other factors. So additionally, some other factors that will increase the possibility of this imbalance are I think it was Anita, you were talking about diet, poor diet. Poor diet is a risk factor, particularly if you've got one of these first two things going on in your lifestyle as well. So when we add on to that, for example, large protein or lipid composition within the diet, that's going to increase your risk. So the nutritional component is not an etiology, but it is a risk factor. Also to consider, now the abbreviation for alcohol, everybody okay? Instead of me writing it all the time, I put a little OH with a little negative to indicate alcohol. Does that work for everybody okay?
Yes.
Yeah, fine.
Okay, that means you can use it in a short answer question as well. I can't speak for anybody else in another classroom, but definitely in ours you can. So this becomes a risk factor, alcohol. So we've talked about two conditions, just getting started, and already alcohol is a risk factor in both. So what do you think the other risk factor might be that would be consistent? Smoking. There'll be a question one day on one of your tests that's going to ask you for one of the most common risk factors for virtually every disease that we've talked to in this class, but generally for every disease that you could talk about. And the answer is going to be choice number A, smoking. I've probably told you this already. Choice B, smoking. Choice C, smoking. Choice D, all the choices above are true. Do you get my point? Smoking is a terrible idea because it increases your risk for every pathology that we can talk about. And if you're wondering what kind of smoking that we're talking about, most of the research has been done on smoking cigarettes. But if you think smoking anything else is going to be different, you're making a big mistake. The smoking is what causes the neoplasia in the respiratory system, which is going to affect your ability to exchange gases in the respiratory system and deliver to cells. And never mind all the other additives that right now are in cigarette smoke. How long do you think it's going to take before big business gets a hold of every other kind of smoke and puts the same sorts of additives in there? Because those additives were designed to get you liking that product more and more and more, making sure you buy that product more and more and more. So as soon as it's become commercialized, like it's becoming, it's going to have a lot of the same factors that we already know are disease producing, or at least risk factors for virtually every disease out there. More research is pointing to alcohol being very similar, but we know for sure that this smoking's an issue. So that's going to be somewhere, if not in more than one place in your future. That kind of a question there as far as that goes. And someone already mentioned it. We know that stress leads to ulcerations as well for some of the reasons that we talked about. I've posted a recording that you may or may not have had a chance to look at just yet on stress that illustrates that pathway that leads to ulceration. That great Canadian researcher, Hans Selye, was the guy who sort of illustrated that even before we knew what some of these hormones were. He knew that there were factors that were being circulated during stress that promoted that triad that I talk about in the recording. So what else do we need to consider? Okay, we've got the pathomechanics, we got the pathophysiology for how ulceration develops. What about the manifestations, the signs and the symptoms? Well, we're going to have some pain. We got inflammation. We've got destruction of some of that mucosal lining. That's going to be painful. And that pain will be abdominal. It'll tend to be a burning, gnawing type of pain. It's relieved by antacids, and it can be relieved by change in posture. And it's often, in this case, opposite to what we saw with esophagitis. This one is going to typically be worse in between meals. So it tends to be worse and part of that's probably because when you're between meals, the overall digestive activity is reduced, but the bacterial activity is going to still progress. This bacteria are still going to be busy burrowing down through this mucosa and interrupting the wall, that mucosal protection, even between meals. So the bacteria is going to be active independent of meal times. So you may also see some bleeding. So there might be some blood in the stool. When there's blood found in the stool, it's sometimes called melena. So that's a term you might see. That's sort of a dark, sort of sometimes described as being tarry feces. So it's an indication, because it's dark, that it happened up in the proximal parts of the digestive tract. If it's bright red, it's going to be lower down in the digestive tract. It's going to be associated with colitis. When we get down to the far end of the digestive tract, we'll talk about colitis. So this bleeding can actually be severe enough, it can be a source of anemia. And that may actually result in enough blood being lost that there's a lower volume of blood, and that blood that lower volume of blood then is not able to deliver oxygen adequately. That's really the definition of an anemia. So we've talked about two types of anemia. This is a hypovolemic type, hypovolemic. But we already talked about a B12 deficiency that can cause another type of anemia. We could have obstruction. So in this case, the edema, the swelling that occurs as a result of the inflammation may promote some spasm and some scar tissue. If it's close to the pyloric sphincter, it might inhibit the emptying of the stomach. If we inhibit the emptying of the stomach, then the food is going to have to move in the opposite direction, and that means vomiting. So we could have edema, we could have scar tissue, we could block or delay stomach emptying. Could lead to vomiting. Or at the least some reflux. If we get perforation, we already mentioned that. That's going to give rise to peritonitis. Peritonitis can lead to sepsis. And sepsis is a type of shock, becomes life-threatening. So when we look at treatments, treatments are going to be pretty straightforward, at least early on. We want to remove risk factors. So no more smoking, no more drinking. Now, rarely, but still regularly enough, surgery is sometimes required. And the surgery is described as something called a gastric resection. So if the ulcerations are getting close enough to become a perforation, then a surgical procedure is going to be required to remove that segment and reattach the healthy segments on either side of it. So that's because you're removing a segment, that's a resection. So part of the treatment for severe gastric ulcer is going to be a gastric resection. Sometimes in gastric cancers, that's the answer too, an area that's been badly damaged by neoplasia. But the issue with a gastric resection is it creates its own complications. As you can probably imagine, one is you're going to lose total surface area for the functions of the stomach. So you're going to particularly interfere with the ability to effectively digest proteins. And to a lesser degree, some of the other components that have a little bit of digestion going on in the stomach. But as an entire mixer, we've lost some surface area, so we've lost some time in the stomach. So one of the concerns that we're going to have, in addition to that, what I just mentioned, is that we're going to have a reduction of that intrinsic factor, which could lead to a B12 deficiency anemia for the reasons that we talked about before. Another complication that's a big concern when you take out part of the stomach, which is relative to what I was talking about, it's called, you create something called a dumping syndrome. And it's a little bit like it sounds. With the dumping syndrome, what we're doing is we're dumping, because of the reduced time in the stomach, we're going to dump additional volumes of undigested foods into the small intestine. Small intestine is not really prepared for that very effectively. So in the dumping syndrome, what's happening is large volumes of food that have not been completely digested are going to enter the small intestine. So we call this becomes, so we'll just say there's an increase in what's called hyperosmolar chyme. So the chyme is what we call the food that was introduced from the mouth, esophagus into the stomach and mixed with the stomach juices. That's chyme. Now, when it's not digested effectively, it's hyperosmolar. There's more mass in the chyme than what would normally be delivered to the small intestine because the stomach doesn't have the volume or the time to properly digest. So that hyperosmolar chyme is going to cause a fluid shift in the interest of equilibrium. So where's the fluid going to come from if we're going to cause this fluid shift? So this fluid right now is in the small intestine. Where's our most readily available fluid volume going to come from in order to try to dilute this fluid?
The cells around it, like in the mucosa.
Okay, so that's sort of right, but where would those cells get extra fluid from? We're going to get it ultimately from the plasma, right? Remember, what we've got is we've got a group of cells, doesn't matter where we're talking about in the body, a group of cells here, and passing by that group of cells is a blood vessel. And that blood volume is readily able to be exchanged at capillary levels because they're low pressure, leaky vessels, and that's how we deliver nutrients and gases. But if there's a demand for volume, either inside the cell or on the other side of these cells, as is the case with the small intestine, then what's going to happen is we're going to take the volume ultimately into the interstitial space and then into in this example, the small intestine, to try to reestablish osmolarity, right? Equilibrium, homeostasis. But what the result of that's going to lead us to is low blood pressure. And the other thing that happens, and this is a little bit counterintuitive, but the other thing that can happen here is that this can lead us also to a hypoglycemic condition. Hypo, not enough glucose in the blood. And that's because what we're going to see is because of this dumping into the small intestine, we're going to get a very rapid absorption of glucose, which is going to require an equally rapid release of insulin. So we're going to have, short term, we're going to have hyperglycemia, requires a very fast response from insulin. It's going to over respond. And again, hyperglycemia because of dumping, hypoglycemia because of the insulin response. And now we're dealing with hypoglycemia. Because we were, rather than being regulated, it was dumped. So this is sometimes called a type of rebound hypoglycemia, right? Because it was responding to a dumping of glucose and over responding or rebounding in terms of promoting this hypoglycemia. So that was hyper. Now we're dealing with type O. Does that make sense? We okay with that?
Yes, thank you.
Okay, let's see here. I want to talk a little bit about some of the common types of bacterial or food poisonings. And then we can move to the, do you want to take a break right now, or do you want to go for one more thing's kind of related to the stomach, and then we're going to switch out of the stomach to the intestines?
Can you do the one more thing then?
Okay, let's do this. What I'll do is I'll make a little bit of a chart for what we call, as a category, we're talking about gastroenteritis, which is, when you see gastro, remember I said it's stomach, and entero is intestine. So these, in fact, are going to be a general term for infections caused by bacteria in either the stomach or intestine. So these are going to, the ultimate result in any of these cases is we're going to have inflammation, of the stomach or the intestine. And our main etiology, our main cause for this, primary etiology being infectious agents or organisms. So basically, it's going to be the location of the infection that'll determine most of the signs and symptoms. In other words, if the location of the infection is in the upper GI, you're more likely to be dealing with nausea and vomiting. If it's in the small intestine or the large intestine, it increases the chances for your symptoms to be more along the lines of diarrhea or cramping or any kind of fecal urgency, which is really another way to describe diarrhea. And the diagnosis is going to be based on the history and also this presentation that's going to help point us towards an effective type of diagnosis. So the types of things that increase your risk for these types of presentations are an increase in antibiotic use. So this is a little counterintuitive as well. So I'm saying that you could increase your chances for a bacterial infection by increasing the utilization of antibiologics. So where's the logic in that?
Because you're killing your gut flora when you take it.
Absolutely. So this is providing an environment for opportunistic infections. That's right. Exactly that. Exactly that. So anybody who's immunocompromised, and the very old or the very young. And both of those last two are because we don't have the same sort of vigilance in the immune system if we're older or if we're very young. It hasn't developed yet in the very young, and it's losing its sensitivity in the very old. So these sorts of factors are going to come into play here. So what we can do is we're going to make ourselves a little chart to kind of summarize this. Your PowerPoints and your textbook can give you a little bit more detail, but in terms of the types of questions I might ask you, you should be able to answer most of it from this chart. So we want a column for the pathogens. We want a couple of examples of a source. Maybe when we would expect the presentation. So remember that was a period from onset to symptoms would be incubation. And then what the basic pathomechanics are. So the first one we're going to talk about is a bacteria called Staphylococcus aureus. Staph aureus. So Staphylococcus aureus is a common bacteria that grows on our skin and is part of our normal flora on our skin. But if it comes in through a food source, the digestive system is not as equipped to deal with it as our skin is. So this is our pathogen. How we introduced it to the digestive system, our incubation, the pathogenesis, in other words, how it causes problems, and then our signs and our symptoms. So with staph, the primary mechanism of entry is going to be from food that is not cooked well. So food preparation was incomplete or not at all. So the source is going to be from uncooked or poorly cooked foods. And the one thing about Staph aureus is it's extremely heat stable. So sometimes we think, well, if we boil our food effectively, then we kill a lot of bacteria. And that's true for a lot of bacteria, but it's not very true for this one. Staphylococcus aureus is described as being heat stable. So you can boil it and it'll probably survive. Anything less than 30 minutes of boiling is probably going to still allow the Staph aureus bacteria to survive. So this is a type of bacteria that releases a toxin. It's very fast. So it releases a toxin that causes inflammation in the stomach and the very proximal part of the small intestine, but typically the stomach. So we're going to have symptoms that, like we described. Nausea, vomiting, maybe some diarrhea as it progresses along the length of the digestive tract. But with all those losses of fluids, we're a little bit concerned about a loss of blood pressure overall as well. Now, next very common bacteria, E. coli. Let's this is a common bacteria. We consider it commensal. We live in harmony with it in the GI tract, especially in the large intestine. But some strains become virulent when they're introduced to us through a food source. And sometimes that food source is kind of gross, but if the food hasn't been cleaned properly, there's some fecal contamination and it becomes part of the food prep. It's also, E. coli is also found in water. So, if you're for some reason drinking pond water or something along those lines, uncooked or poorly cooked meats like poultry. So this is a little bit longer incubation, but still relatively quick, say 10 to 12 hours. Also releases an enterotoxin, a toxin that's going to irritate the linings of the stomach and or the small intestine. So we'll just say it's very similar to the one above. And again, we're going to see vomiting, which is an indicator that it's happening early along the tract. But because it's a little bit longer, we're going to have the presence of this bacteria further along the tract. We also can see, so you can start to see there's some real overlap. And the biggest differential right now so far with what we've been talking about in these two is going to be the time of onset, the incubation period. Probably some cramping. Now, there's one here that most of us have heard of before, Salmonella. Full name is Salmonella enterica. So you can see with that enterica, it has something to do with the intestine. So the most common location for Salmonella enterica to be able to enter is from eggs and poultry. Takes a little longer now. Our chart really is going longer in onset time, maybe a couple of days. And what we're getting with Salmonella is we're getting a bacterial immune reaction. So the bacteria Salmonella releases endotoxins when the bacteria is killed in the stomach. And then it takes a couple of days before the immune reaction gives rise to some symptoms a little further along the track. So we would see, so it's an endotoxin released on after, oh boy. So I just put with HCl, with contact with the acids in the stomach. And then what we're going to get is some diarrhea, cramping. But again, the key thing here is the onset's a little bit later than the one up above it. And because there's a more systemic type of immune response, we're probably going to see some fever associated with this one as well. And then we can talk a little bit about Clostridium botulinum. Clostridium and again, proper taxonomy would be, so botulinum is the correct terminology for the bacteria. This is an anaerobic. We mentioned this when I was talking about Clostridium tetani, anaerobic. So this is the food poisoning that can grow in cans. The Clostridium tetani is often found in soils. So you put the soil contaminated with Clostridium tetani into an open wound and you increase the chances of colonization that way. In this case, you're ingesting Clostridium botulinum through a food source like contaminated canned foods. The spores grow in the food. They can grow in a can that's sealed from oxygen because it's an anaerobic bacteria. So spores in food. And this is another 1 to maybe 2 days. And it releases, just like tetani, but it's a different type of neurotoxin. In this case, the neurotoxin that released is the neurotoxin blocks ACH release at if we block the ACH release at a neuromuscular junction, what do we get?
There's no contraction.
That's right. So that'll be manifested as muscle weakness, which could progress to paralysis, especially if it affects the muscles associated with breathing. So it can lead to respiratory failure. All from eating that can of beans that had a little bit of spore growth in it. So that's one of the concerns we have with this particular type of food poisoning. So these muscle weakness, paralysis, respiratory failure all fit into the manifestations here. Okay, so that's a summary of some of these things. You can spend a little bit more time filling in some of the details, but if you can kind of visualize this chart, it's going to cover most of the types of questions that I would ever ask you about this particular topic.